Welcome students, this is Dr. Deptee Warikoo, MPT, Department of Physiotherapy, Dolphin PG Institute of Biomedical and Natural Sciences, Dehradun. Our today's topic is carpal bone fracture. There are 8 carpal bones at the wrist, situated between the radius and the ulna in the forearm and the metacarpals in the hand. The most common carpal fracture is that of scaphoid. Among the other carpal bones, only the triquetrum, hamate and pisiform are likely to be fractured in isolation. Other carpal fractures are seen more commonly in conjunction with other fracture injuries. Most isolated carpal fractures are caused mainly by the direct trauma. So first we will be starting with the scaphoid fracture. So first fracture we will discuss will be the scaphoid fracture. The scaphoid fractures are the most common carpal fractures in young children and the elderly population. The scaphoid fracture is rare. The scaphoid bone is stronger than the relative weak distal radius in these age groups. A delay in diagnosis of scaphoid fracture can lead to variety of adverse outcomes. That is why this fracture becomes more important. Even if not treated, then there is chances of getting osteoarthritis of the radiocarpal joint. They are common in children. Scaphoid fracture are produced by wrist hyperextension, where the hyperextension is greater than 90 degrees, and this hyperextension of the wrist is accompanied by a radial deviation. Now the fracture of this bone, scaphoid, could be categorized into mainly 3 types: the proximal pore fracture, the waist fracture, that is the middle fracture, and the distal pole fracture, that is the tubercle fracture. The scaphoid fracture is very important, so we need to know where is the exact fracture occurring. If we talk about the epidemiology, as we have already seen, scaphoid fracture accounts for 50% of the acute wrist injuries. Sorry, 15% of the acute wrist injuries. Scaphoid fractures have a high incidence of non-union also, and good incidence of post-traumatic arthritis. So that is very important. That makes it important that we should diagnose it properly and timely. No blood vessels enter the proximal pole of the scaphoid. Thus, a higher incidence of aseptic necrosis and non-union is noted with fractures on this side. Now, what are the types of fractures? As we have already seen, you could see the first one, the waist fracture. Here you could see the 3 types of fractures of scaphoid. Waist fractures are the commonest fractures and may be explained by the anatomic location of the radioscaphocapitate ligament. This is very common. This ligament runs directly palmar to the waist of the scaphoid, and during high energy loading, forces are concentrated in the contact area between the scaphoid waist and the ligament. Then the distal pole fractures account only for 10% of the fractures, whereas the proximal pole are involving 20% of the cases. The vascularity, as I already told you, of the scaphoid greatly influences the prognosis. More than 90% of these vessels entering the distal to the scaphoid waist. So if there is any waist fracture, it may necessarily interfere with the blood supply of the particular area or the bone. That is very important. That we have to notice, that we know about that. Then based on the intraosseous blood supply and location of the fracture, the occurrence of avascular necrosis becomes high or low. The proximal pole, which is entirely covered by the articular cartilage, is as particular risk because of retrograde nature of the intraosseous blood flow. That is, the artery rotates round down. The incidence of avascular necrosis of the proximal pole approaches about 100% and is directly related to the size of the proximal pole. Now, evaluation of the fracture. We have to take the history, how it is done, the mechanism of injury, then do a physical examination, and then X-ray is very important to see which type of fracture it is, and on the basis of type the management will be designed. when we physically evaluate the area, we see there is tenderness over the anatomical snuff box. Pain could be palpated over the scaphoid tuberosity, and there is limited painful rest range of motions and very severe pain in dorsiflexions. X-ray, CT, MRI or bone scan could be asked the patient to get it done. Then the rate of scaphoid healing depends on multiple factors. First one, the proximal pore fractures have a high rate of non-union. Displacement of greater than 1 mm is critical and is associated with soft tissue injuries, which will preclude predictable bone healing. Third one, Lunate's dorsiflexion, if it is greater than 15 degrees, is accompanied by a scaphoid fracture. This makes carpal bones unstable. Fifth one, vertical oblique fractures are unstable to compression and shear, therefore will be less likely to heal. There are complications of the scaphoid fracture, like first one is the non-union. It occurs mainly because of the undertreatment or misdiagnosis. If the non-union has been long-standing and not treated properly, often the distal portion of the scaphoid palmar flexes and the lunate gets dorsiflexed. This is termed as SNAC lesion. SNAC stands for scaphoid non-union advanced collapse. A CT can demonstrate this with a hunchback deformity and a non-union. Then SNAC deformity is a dissociative carpal instability in which the kinematics of the wrist will be totally altered. The scaphoid and lunate will work abnormally, and bone grafting is mandatory in the treatment of scaphoid non-unions. Second most important complication is avascular necrosis after the SNAC. In the fracture of the waist and proximal pole of the scaphoid, the blood supply to the proximal fragment may be cut off. This results in avascular necrosis. In such cases, excision of proximal fragment and radial styloid gives good result. Third complication could be osteoarthritis of the wrist. It develops in later years following any avascular necrosis or any non-union. When we talk about the treatment of scaphoid fracture, stable non-displaced fractures of the waist of scaphoid or the distal pole can be treated with closed reduction. If there is a distal scaphoid fracture, it heals within 8 to 10 weeks. So we could give short arm thumb spica casts. Fractures of middle portion of the scaphoid require 6 weeks of long arm thumb spica cast, which are followed by 6 weeks of short arm thumb spica cast. Then the proximal fractures are treated non-operatively and require 6 weeks of immobilization in a long arm thumb spica. Again, same, followed with a short arm for the coming next 6 weeks. Proximal pole fractures, which is poorly vascularized and is the most unstable fragment, this type of fractures need operative management. Treatment of displaced unstable fractures includes closed reduction and percutaneous pinning. Open reduction and internal fixation with a compressive screw is also favored by most of the surgeons. The scaphoid may be approached volarly or dorsally. A dorsal approach is relatively straightforward. After scaphoid open reduction internal fixation with stable fixation, a wrist control splint is used for 2 to 4 weeks to allow for earlier soft tissue healing. This is very important. Then a removable orthosis is then worn until bone goes for union. Now, rehabilitation protocol for first 6 weeks, sugar tongue thumb spica cast could be given, active shoulder exercises could be given, active 2nd to 5th MCP, PIP, DIP range of motion activities could be given. For the coming 6 weeks, that is from the 6th to 12th week, non-tender to palpate painless range of motion with cast off exercises could be given, short arm thumb spica casts could be given, continue shoulder and finger exercises, begin with active elbow flexion extension, supination pronation exercises. For the coming 12 weeks, again do a CT to confirm the union of the scaphoid. If not, then continue with the immobilization. Otherwise, 12 to 4 weeks, assume union. At 12th week, remove the thumb spica and begin home exercise program. Home exercise program includes all the gentle exercises of MCP, wrist and IP joints. For coming 14 to 18 weeks, discontinue all splints. Do all the occupational therapy exercises like strengthening, functional exercises, grip strengthening, unrestricted activities. Scaphoid fractures treated with open reduction and internal fixation. For first 10 days, elevate sugar tongue, thumb spica and give ice. Give shoulder range of motion exercises, MCP, PIP, DIP joint active range of motion exercises. For coming 10 to 4 weeks, for the coming 10 to 4 weeks, the sutures will be removed and then exercises will be started, hand and shoulder exercises. For 4 to 8 weeks, short arm thumb spica cast, elbow active assisted exercises should be continued. After 8th week, again do a CT scan and confirm the union of the fracture. Then after 8th week, same exercise protocol will be followed with all the exercises like wrist flexion extension, gentle exercises to thumb, wrist, thenar muscle strengthening. Then after 10 weeks to 14 weeks, discontinue all splints, formalized occupational therapy. After 14 weeks, start off with grip strengthening and aggressive range of motion exercises. All the functional activities will be given after 14th week. This is how we will manage a scaphoid fracture. Next fracture is the lunate fracture. This is the isolated fracture of lunate. Unusual and more commonly are a manifestation of Kienbock's disease. We already know about Kienbock's disease. The lunate may be fractured through its body following a fall or extended hand. Fracture of lunate is often missed on X-rays. So if X-ray is not showing it, you could go for CTs or MRIs. Lunate dislocation is seen, rare dislocation of wrist. There are two types lunate dislocation. It could dislocate anteriorly but rest on the carpal, or pre-lunate dislocation, the lunate remains in the position and the rest of the carpals get dislocated. These are the two types you could see. There are complications. The first important complication is the avascular necrosis of lunate, that is the Kienbock's disease. The Kienbock's disease is related to ulnar negative variants and variations of the interosseous vasculature of the lunate. Then treatment of avascular necrosis depends on the stage of involvement, and it has to be treated properly for avoiding further complications. Now the management of lunate fracture or dislocation. The conservative management involves immobilization in a below elbow plaster cast for about 3 weeks. Dislocation of lunate needs reduction under anesthesia followed by immobilization in a below elbow plaster cast for about 3 to 4 weeks. Physiotherapy management will be divided into two phases, first during the immobilization and second during the mobilization. During immobilization, maintain the strength and full range of motion on uninvolved joints, positioning of the limb and supervised vigorous and slow stretched finger movements. Then in mobilization phase, then it may be used before initiating the mobilization. Hand splints could be used. Then mobilization following relaxation should be started in gravity eliminated position. PRE should be started. PRE is the progressive resisted exercises to the hand. They should be started using low weight dumbbells. Hand functional activities should be started after the in the mobilization phase. Generally these exercises are started after 8th week. Generally accepted results could be achieved within 8 weeks. Return to heavy exercises after 6 months. Next fracture is the capitate fracture. The capitate is the largest bone in the wrist, stabilized by its articulations as well as by the strong ligaments which support the capitate bone along. 80% of the fractures are due to the force generated by the use of hand, which is transmitted across the capitate onto the lunate and then onto the scaphoid and subsequently to the radius. Isolated fractures of capitate are very uncommon. It is mixed fractures which we see in capitates. Most commonly, capitate fractures occur when an associated transscaphoid transcapitate prelunate fracture dislocation of the wrist is there. The scaphocapitate syndrome, as we call it, where we have scaphoid, capitate and lunate all getting affected. In this syndrome, proximal pole of capitate rotates 180 degrees, full tilt, and its intraosseous blood supply is also disrupted. The complications of capitate fracture could be avascular necrosis, which is mainly seen over the pole of the capitate. To identify the fracture, we go for radiographs. Mainly, initial radiographs will show it undiagnosed. You could go for CT scans if radiograph is not showing it properly. When recognized and properly immobilized, these fractures generally heal and revascularize of the proximal pole is possible. If unrecognized fractures, repetition movement subsequently leads to resorption at the fracture site. There could be non-union or failure of the proximal pole revascularization also there. If non-union with avascular necrosis develops, then it is difficult and the prognosis becomes weak. There could be also degenerative arthritis seen due to this kind of fracture. So it needs proper management. The physiotherapy management will be exactly like we see in the lunate. Next are the hamate fracture. Fractures of the hamate can be divided into following the fracture of hook of the hamate or fracture of the body of the hamate. So this could be classified into hook fracture and body fracture. Fractures of the hook are most common and are the result of force transmitted through the base of the palm, typically found associated with the history of an improper golf swing. So golfers mainly or the tennis players do show hamate fractures. Pain is located over the hook, around the hook, but can also be present over the dorsal aspect. We cannot say that only the palmar aspect will have the pain. Again, if we go for the radiographs, sometimes it is unable to be diagnosed on radiographs. Patient is not able to dorsiflex the wrist frequently or adequately when we tell him to do so in the physical examination. Again, I am telling you, if it is not diagnosed properly on X-ray, you could go for the CT scans. Acute non-displaced fractures may be treated in a short arm cast. Usually this heals within 6 to 8 weeks. If there is a displaced fracture, then it requires a surgery. Displaced fractures are mainly treated with screw fixation, which provides a better fulcrum for the extrinsic flexor tendons. Pain located directly over the hook may be associated with ulnar nerve neuropathy and flexor tendon rupture. Once exercised, a compressive dressing is applied over the wrist until the wound heals. Okay? Fracture of the body of hamate are accompanied by fractures of the base of 4th or 5th metacarpal. If non-displaced, again you can go for short arm casts, and if displaced, again I am telling you, then you have to go for open reduction internal fixation. We could go for K-wire fixations or normal plate fixations. Management of the hamate fracture will also be exactly in the same manner as we manage the lunate dislocation and fractures. So you will follow the same pattern. So this was about the fractures of the carpal bones. These are the important fractures. If anybody has any doubt, you could ask me. These are the reference books you could follow. If anybody has any doubt, you could ask me, message me, call me, WhatsApp me or email me on my email ID. Thank you so much. See you in the next class.